Okay, so we're going to look at cardiac meds, and what we're going to talk about today on this lesson is we're going to look at hypertension. And so when you're talking about hypertension, hypertension can be either primary or essential hypertension, where the cause is unknown, and that could be a combination of familial or genetic, and then environmental factors. And then there's also secondary, where you actually know what's causing or contributing to the hypertension. And so when you're looking at hypertension, the things we're considering is the variables that consider blood pressure. So blood pressure equals stroke volume times heart rate times peripheral resistance. Now, typically what we're looking at when we're looking at hypertensive states is we're looking at an increase in peripheral resistance for a number of reasons. So what I wanted to do is I wanted to just walk you through a common scenario where we know, a secondary hypertension, where we know what's causing the increase in peripheral resistance, but also some of the other factors too. So, for example, with a secondary cause of hypertension, it could be something like a renal disease. And so if I look at somebody that has diabetes mellitus, over the course of time, they'll start to get nephropathies. And with nephropathies, what's happening is you're starting to get sclerosis, both hyaline sclerosis and atherosclerosis of the vasculature within the kidneys. Now, we've mentioned before that about 23% of your cardiac output at rest goes to the kidneys. Well, if this is sclerosed in here and I'm not getting good blood flow to the kidneys, that creates a hypertensive state within the vascular system. But it's going to be compounded because, one, I'm creating hypertension just because I'm not getting that flow to the kidneys at rest. But then the other thing that happens is that decrease in renal flow is going to activate the renin-angiotensin aldosterone system. So as I decrease the renal flow, I'm going to drop the pressure in the afferent arteriole here. So what this is you've got the little glomeruli out here, the nephrons. This is the nephron and the glomerulus. So I'm decreasing the flow in the afferent arteriole. As I decrease the flow in the afferent arteriole, that is going to take these mechanically gated calcium channels and close them. And so in the JG cells, we have what's called the calcium paradox. If I have a decrease in calcium entry, I'm actually going to increase my release of renin. So now I release my enzyme renin. So what renin is going to do is renin, of course, is going to convert angiotensinogen, and this is a liver plasma protein, and it's going to convert it into angio-1. And then angio-1 is not really going to do much of anything. However, as it goes through the vascular system, the endothelial cells produce angiotensin converting enzyme. And that converting enzyme is going to make it into angiotensin 2. All right. Now, angiotensin 2 has lots of physiological effects that are going to contribute to my increase in blood pressure, and so and contribute to my hypertensive state. So we'll just kind of walk you through those, and then we're going to look at the drugs to treat those. So one of the things that angiotensin does is it causes the release of norepinephrine from the sympathetic postganglionic fibers. So we talked before that your driver for the sympathetic nervous system is your rostroventrolateral nuclei. So here I have the reticulospinal tracts that form the fibers of this. And so normally the activation here is going to result in the release of norepinephrine from the axonal ending. However, here what I have is I actually have an AT1 receptor on the end of these releasing fibers. And so what that's going to do is that's actually going to increase the release of norepinephrine onto the alpha-1 receptors. Another thing is angio-2 is going to come over here and it's going to plug into the AT1 receptors. The AT1 receptors, when they're activated, they activate the same receptors that the alpha-1, or the same pathways that the alpha-1 did. And so I'm going to activate both alpha-1 and AT1 is going to activate my GQ protein, activate PLC. PLC is going to activate IP3. IP3 is going to plug into the sarcoplasmic reticulum, and I'm going to release calcium. When I get calcium, I get my calcium cohomogen complex. That's going to take inactive myosin light chain kinase, and that's going to make it active. When I have active myosin light chain kinase, that is going to split ATP into ADP plus phosphate. That phosphate then is going to be given to my myosin, and that's going to get me contraction. So what I'm doing now is I'm producing this hypertensive state. So angiotensin 2 is very strong, creates very strong vasoconstriction. So far we have it plugging into the AT1 receptor, activating this pathway, resulting in peripheral contraction. We have it increasing the release of norepinephrine from the postganglionic fibers. But there's more that it does. Angiotensin 2 can also come over here to the catecholamines, and the catecholamines are released from the adrenal medulla, and on these cells we have AT1 receptors. So now what I'm doing is I'm increasing, by activating those AT1 receptors, I'm increasing norepinephrine and epinephrine release from there. So that in turn is going to plug into my alpha-1 receptors to increase my peripheral resistance, but it's also the epinephrine, norepinephrine are going to plug into my beta-1 receptors on the SA node and on the contractile myocyte. So I'm increasing my stroke volume, my heart rate, and my peripheral resistance. If that's not enough, another thing that angiotensin 2 can do is it can actually go to AT1 receptors on the rostral ventral nuclei, and it can increase sympathetic outflow. So now we've got 4 different things that angio2 is doing to increase my blood pressure. It's activating the AT1 receptors on the vascular smooth muscle. It's activating the AT1 receptors on the postganglionic sympathetic fibers. It's activating the AT1 receptors on the adrenal medulla to release norepinephrine and epinephrine. And it's activating AT1 receptors on the rostral ventral nuclei, which is increasing the action potentials along these reticular spinal tracts into the lateral horns, and it's increasing sympathetic outflow. As I increase sympathetic outflow, I increase peripheral resistance, but I also increase my stroke volume and heart rate as I activate the beta-1 receptors on the SA node and myocytes. So you can see that this decrease in perfusion has caused this hypertensive state. But there's more, because another thing that angiotensin 2 does is it goes to the zona glomerulosa in the cortex of the adrenal gland. At the zona glomerulosa, it's going to stimulate that AT1 receptor on the zona glomerulosa. It's going to allow calcium to come in and promote steroidogenesis. The steroidogenesis is of the mineralocorticoid aldosterone. Aldosterone is going to come over to the principal cells in the late DCT and the cortical collecting duct, and aldosterone is going to plug into these mineralocorticoid receptors. So here's my aldosterone. It's plugging into the mineralocorticoid receptors within the cell. That is going to stimulate the synthesis of a sodium leak channel and a potassium leak channel. So now my sodium was being filtered over here at about, I have about 140 milliequivalents per liter of sodium, and my osmolarities over here is about 300. It's about 1,200 here, it's about 100 here, but what I start doing is I start pulling in sodium, and then what I do is I take that sodium and I'm going to kick it out, because the other thing that was stimulated was the sodium-potassium ATPase pump. So I stimulated a sodium leak channel, a potassium leak channel, the sodium-potassium ATPase pump that kicks the sodium out, and then also I drive the sodium-potassium ATPase pump. Now as I pull sodium through here, I'm also pulling water. So aldosterone is onboarding more water. As I onboard more water, my blood pressure increases, my hypertensive state increases. There's more, because on the hypothalamus, you've got the supraoptic nuclei and the paraventricular nuclei. The supraoptic nuclei and the paraventricular nuclei, what they do is they synthesize antidiuretic hormone. Antidiuretic hormone then is stored in the posterior pituitary. So on here, what I have is I have also these AT1 receptors. And so angiotensin 2 plugs into the AT1 receptors, which results in the increased release of ADH. Now, ADH has another name. ADH is also called vasopressin, and the reason it's called vasopressin is because it can cause vasoconstriction. ADH will come over here and plug into my V1 receptors. And as it plugs into the V1 receptors, what's going to happen is it's going to activate the same pathway, this GQ-PLC-IP3, and then I'm going to end up getting the contraction of the muscle. So what we've seen so far with this secondary hypertension with this chronic kidney disease is we are just driving up our blood pressures. So what we need to do is we need to step in pharmacologically and we need to intervene. And so next we're going to look at the medications that we can do to lower down this hypertensive state. So we'll just go through these one at a time. So the first one, hydrochlorothiazide. Almost every patient that has hydrochlorothiazide gets, or every patient that has hypertension, one of the primary medications they get hydrochlorothiazide, because it's really good at getting rid of these blood volumes, especially in the case of this where I'm onboarding it by chronically activating the renin-angiotensin aldosterone system. So hydrochlorothiazide, it's going to block the sodium chloride pump over here in the DCT. So as sodium chloride comes around this way, normally sodium and chloride are taken up in the DCT. But what I'm going to do is I'm going to block that pump with my hydrochlorothiazide. And then we talked about this in another video, that once I block that pump, I'm going to have more sodium coming around this way, and it's going to be pulling water with it. And so as the sodium chloride pull water with it, I'm going to diurese more water, and I'm going to drop my volume. However, we also do have potassium wasting, and the reason for the potassium wasting is because when I increase the concentration of sodium in the cortical collecting tubes, what happens is I do have residual sodium leak channels because of the effect of aldosterone. Sodium is going to come in and it's going to displace that potassium, which is in a high concentration of the cell. So potassium is kicked out as sodium comes in. But a lot of the potassium just goes on through for diuresis. Now, typically what you're going to do is you're going to combine the hydrochlorothiazide with another medication, and we'll look at those in just a minute, either the captopril or losartan, and there's a consideration which one you're going to give. Spironolactone. Now, if your patient has low potassium, you don't want to give them either hydrochlorothiazide or Lasix, because Lasix is also potassium wasting. So if your patient's potassium tends to trend low and you still want to diurese them, then one of the things you can do is the spironolactone, because the spironolactone blocks this mineralocorticoid receptor. So now aldosterone was coming in and synthesizing these various channels, which was onboarding more water, but with spironolactone, it's going to come in here and it's going to compete against aldosterone and block that mineralocorticoid receptor. Once I block that, I'm not going to synthesize my sodium leak channels, and I'm also going to diurese. But in this case, I'm not going to waste potassium because I didn't synthesize the potassium leak channel. Another option for medication is metoprolol. Now, metoprolol is not going to be used in monotherapy. You're not going to give a patient with hypertension just metoprolol. You're usually going to give it as an adjunct to something else. And so with metoprolol, I can block the beta-1 receptor on the SA node, and I can drop the beta-1 receptor on the myocytes. Both of those are going to result in a decrease in stroke volume at the myocytes and a decrease in heart rate at the SA node. But there's one other thing that happens, because over here I actually have beta-1 receptors on the JG cells. When my sympathetic nervous system fires off and releases norepinephrine onto the beta-1 receptor, the result is to release renin. So by giving them a beta-1 blocker, I've not only blocked the stroke volume and the heart rate from increasing, but I've also blocked the beta-1 receptors from norepinephrine, stimulating the release of renin from that. Okay, we come on down. The next thing we have is prazosin. And so prazosin is going to act peripherally, and so what we're doing is we're dealing with this right here, the peripheral resistance. So prazosin is going to come over here to my alpha-1 receptor, and it's going to block the alpha-1 receptor. So now I'm not going to activate this alpha-1 pathway. I can still activate these other pathways, but I'm just not activating this primary alpha-1 pathway, which is driven by the rostroventrolateral nuclei. Clonidine. And so clonidine is an interesting one because it's the only one on our list that's really an agonist. Everything else is kind of an antagonist. And so what I have is these imidazoline receptors up here within the rostroventrolateral nuclei. And so when clonidine blocks these receptors, what it does is it decreases the output. And so clonidine tends to decrease the output, so I'm blunting that drive of the rostroventrolateral nuclei. It also plugs into alpha-2 receptors, and that's where it has its agonistic response, because when I plug into an alpha-2 receptor, I'm going to decrease the release of neurotransmitter, specifically norepinephrine from these axonal endings presynaptically. The next one, risperidone. With this one, it's blocking dopamine entry into the vesicles. So normally what happens is when I'm taking in L-DOPA, I take in L-DOPA into the axonal ending at these postganglionic fibers. It's converted to dopamine, and then dopamine is taken into the vesicles and converted to norepinephrine. So what I do is I give this drug, and it blocks the entry of dopamine into these vesicles, and so it decreases the release of norepinephrine because I decrease my overall quantity of norepinephrine. Hydralazine, and so we talked about this before. A lot of times you give hydralazine for increases in systolic blood pressures. And so hydralazine comes over, and it's thought to increase cyclic AMP because it does similar to nitric oxide. And so what they think is that it increases your cyclic GMP, and by increasing my cyclic GMP, I'm going to come over here and I'm going to activate myosin light chain phosphatase. Myosin light chain phosphatase is going to kick the phosphate off the myosin and also inactivate my myosin light chain kinase. And both of those, of course, are going to result in vasodilation. Nifedipine is a calcium channel blocker. So here I have this L-type calcium channel. Now, when you have excitable vascular smooth muscle, all you have to do is increase the calcium signal to take the resting membrane potential towards threshold to open these voltage-gated channels. But there's also thinking that there's other ways to open these voltage-gated channels. One of them is just to increase your myosin light chain kinase. So as myosin light chain kinase increases, it's thought to increase the opening of these L-type calcium channels. Another option is to activate PLC, activates what's called DAG. DAG activates protein kinase A, and that's also thought to increase the activity of these L-type calcium channels. Now, these are worked out on animal models, and so there's conflicting research, but right now it looks like an increase in myosin light chain kinase can phosphorylate the opening of these L-type calcium channels. So what you can do is you can give them nifedipine. Nifedipine will block the entry of calcium through these L-type calcium channels, and so you just have less calcium signaling in the cell, and so you get vasodilation because of that. Captopril. So captopril is your ACE inhibitor. So if I can block ACE, I can block the conversion of angiotensin 1 to angiotensin 2, and this doesn't happen. And so all of the places where you see AT1, all these AT1 receptors, I'm not going to activate them because I'm not getting angiotensin 2. However, there is a concern because ACE is also called kinase 2. And so kinase 2 is synonymous with ACE, and that's just the enzyme that's released by these endothelial cells. Now, the problem is this. If I give you captopril or any of the prils, it blocks kinase 2. Well, kinase 2 breaks down bradykinins. And so if bradykinins are active in this area, what it does is it causes inflammation in these areas. And so you get an increase in tissue inflammation. And so that's where you get your dry cough. And so with angioedema, since I block the kinase 2, I'm getting angioedema that's actually pushing in on the airways. And so if that's the case and the person has the dry cough because of the angioedema, then you're going to take them off the ACE and put them on the sartan. And so losartan would be your example there. So with losartan, it's a little bit different because here with captopril, I block the enzyme. With losartan, I'm blocking the receptor. So now every place where I have angio2 plugging into my AT1 receptors, I've blocked those receptors. One of the nice things about losartan is we know that angio2 does have an effect on the cells, on the myocardial cells, where it can cause some cardiac remodeling, and so the cells get bigger, but they get weaker, and you also get more extracellular matrix. And then finally, eplerenone is my last one. And so with this one, what you're doing is you're blocking the mineralocorticoid receptors. And so we can actually just go back here. It's the same as the mineralocorticoid receptor here. So where aldosterone was plugging in, we can just go ahead and block that mineralocorticoid receptor. All right, so that, anyway, if you have questions, you can email me. Otherwise, we'll see you next time.